and all the other sessions that we already had on Congenital Heart Academy, and you are going to be able to share with your team and your colleagues, and this is going to be very good to all of them. So I'm very glad to say that we are going to have on Mondays, on the 3rd of November and on the 7th of December, is going to be a big webinar divided in 2 parts to celebrate the 76th anniversary of the BTT shunt. So it's going to be very nice. We're going to have people from all around the world to talk about tetralogy of Fallot and BT shunt, including one of the first patients, the patient, if I'm not mistaken, number 44, who received a BT shunt. So this is going to be a very special session. We have people from all around the world, and really hope that all of you can join us on both sessions. And then on the 1st of December, on Tuesday, we are going to have a very special session talking about how what we do on the cardiac ICU impact on the quality of life of our patients. Things that we don't see because we are inside the CICU, right? But we are going to talk about how what we do on the CICU, on the early post-op care or before the surgery for our patients is going to impact their lives. So this is going to be very nice. Please invite all of your team, nurses, nurse practitioners, all the multidisciplinary team is going to be super welcome on this session. This is a joint meeting from CENOC and PCICS, and we are very happy for that. On December the 8th, Gil is going to have a very nice one of his sessions, and we are going to talk about a lot of topics. We are going to talk about women in pediatric cardiology with our DO, Marin Cohen. We are going to talk about teamwork, training, leadership, and much more. Please join us on December the 8th. And on the 14th of December, we are going to have another session from Dr. Norman Silverman, who is with us today as well. We are very happy to have you here in this Dr. Anderson sessions, Dr. Silverman. Thank you for that. And so please watch this one live, because this one is not going to be available on YouTube. So place that on your calendar and be with us on the 14th of December. And then more to the middle of the month, we are going to have on the 17th of December, one update on fetal cardiology with very nice people from all around the world. And so today we are going to have one more of Dr. Silverman's session, just to let you know that we are going to have a little bit of a change. So next week, we are going to talk about aortic coarctation and interruption. And then we continue on the normal series, how to say that in English? And with the other topics, the way that we have scheduled. So thank you very much for attending. Please type your questions on the Q&A chat box. All of us are going to be very happy to answer your questions and to use your questions on the discussion in the end of the session. And today we are very, very proud to have Dr. Justin Tretter here with us. Dr. Justin is a pediatric cardiologist with a special interest in imaging. He's from Cincinnati Children's Hospital, and he is the editor of Heart University. And now he is going to talk a little bit with us. Thank you very much, Justin, for being with us today.
All right. All right, so I think in the last session, you guys had covered the aortic root. So Professor Anderson had asked me to cover briefly some of the intricacies of 2D imaging of this complex structure of the aortic root. And a lot of this is generalizable to the pulmonary root as well. So as you guys reviewed last week, and we'll probably cover again today, both the aortic root and the pulmonary root are made of 3 components: the leaflets, the sinuses, and the interleaflet triangles. And so for both of them, the virtual basal ring is a very dynamic structure. It's ovoid or sometimes D-shaped in diastole, and then it becomes more circular shape in systole. And the virtual basal ring, or the quote-unquote annulus, is nothing more than connecting the dots. Down here you see these 3 dots, the green, the yellow, and the red, and we're connecting the dots of the lowest attachment of each of the leaflets to create this virtual basal ring or echocardiographic annulus. And so we wrote this article last year primarily to describe some of the difficulties of assessing the aortic root on multiplane reformatting by computed tomography. But I wanted to focus here and apply this to how we're looking by echocardiography in the long axis at both the aortic root and at the virtual basal ring. So if we look at panel E and panel H, when we're opening up the sinuses, it can be very difficult and sometimes difficult to reproduce to get into the largest aspect of the sinuses. So here you see a significant difference of about 5 millimeters. And if we relate that to the short axis of the aortic root, and if we look at this line here where we're cutting across from the central aspect of each of the sinuses, which should reach the nadir to nadir of each of the leaflet attachments, and then as we hover within the root, we don't get to its greatest extent until we come more centrally. And the same thing when we're looking at the virtual basal ring, we can get significant different measurements as we hover between the sinuses. So in this example, we're going from 15 to 22 millimeters. And if we relate that to the short axis of the virtual basal ring and diastole, which again is a more ovoid shape, we're hovering from this almost nonsensical oblique plane within the virtual basal ring. So you can see how we can get significantly different values and whether this really represents the true dimensions of this ovoid structure. And so one of the things that I wanted to bring up as we've started to look in detail at some of this anatomy, one of the important features that we've noticed in normal patients, let alone those with congenitally malformed aortic valves, is that there's a significant variability in the rotational position of how the aortic root sits on the base of the left ventricle. So most commonly, the aortic root is centrally positioned, where the non-coronary leaflet will line up almost with the midline of the aortic leaflet of the mitral valve. So we see here that aortic to mitral fibrous curtain with the midline almost lining up with this interleaflet triangle between the non and the left coronary leaflets. And that is the most common arrangement in about 50% of normal children and adults. But we've noticed in the other quarter, there can be variability either counterclockwise or clockwise rotation. And the other significant thing that we notice is that there's strong correlation between the support of the aortic root, the ventricular support, whether it's fibrous or muscular tissue. So in the extreme of clockwise rotation, we see that there's much greater fibrous support. About 70% of the aortic root is supported by fibrous tissue, as opposed to this red line showing muscular tissue. And at the other extreme, the counterclockwise rotated root, it's about 55% muscular support. So this has raised a lot of clinical questions, and I don't have time to go into this detail, but we've published some material on this, and we're continuing to investigate what this means in regard to how does this impact the structural integrity of the aortic root and valve? How does this impact the resulting hemodynamics and the resulting tissue biomechanics on the aortic root and the thoracic aorta? And how does this change the relationship of the aortic root to the atrioventricular conduction axis? And again, we don't have time to go into this detail today, but there's a lot of interesting findings that we're looking into. So the important thing is that, yes, we notice this in the heart specimens, but we also can assess this in the living patient by CT, and we also have studies where we're looking at this by echocardiography. So by CT, we've described in normal adults this same significant variability between the more common central position versus clockwise versus counterclockwise rotation of the aortic root. And we can actually quantify the angle of rotation. And likewise, we can quantify the degree of muscular versus fibrous support. So here we see that clockwise rotated root with more fibrous support. Here we see the counterclockwise rotated root with more muscular support. And important when we're considering the virtual basal ring is these two panels below, C and D, which shows the aortic root superimposed over top of the virtual basal ring. And you can see by these colored triangles, which represent each of the interleaflet triangles and commissures, when you compare the yellow to yellow, and you can appreciate that significant difference in the rotational position, then you can appreciate that how with this variability, that's going to position the different sinuses in a different plane over this virtual basal ring structure. So if you think about echocardiography in your long axis image, where you're often cutting between the non and the right coronary sinuses and leaflets, you can appreciate how you would get very different oblique measurements, whether you're looking at a clockwise versus counterclockwise rotated aortic root. So this is very important for a number of reasons. And one of the things that I've begun to focus on is how can we use some of this detailed information to plan for aortic valve surgery. And Dr. Hans Schaefer is definitely one of the leaders in aortic valve repair and using this very detailed metric measurements of the different structures of the aortic root to try to improve on aortic valve repair. And they had this nice review in 2019 in JACC Cardiovascular Imaging, where they showed how they're doing their planning with three-dimensional echocardiography, looking at not only the measurements like the virtual basal ring and the sinotubular junction, but also measurements like the geometric height, the coaptation length, the effective height, the commissural length, things that we won't really be able to get into detail with, but structures that are important to understand good coaptation for the aortic valve leaflets. So we publish on this to really try to understand better these metrics, since they require precision. And one of the concepts, like we talked about before, or actually I skipped over, but I'm going to come back here to this image here. So if we truly want to get a good measurement of this oval structure, like what they would do in TAVR planning, where they get a minor and a major axis, to get that minor axis, we would have to go into the center of the right coronary sinus and leaflet, and we would have to cut across to the opposite commissures between the non and the left. And on echocardiography, if we did that, we would open up the right sinus, but we would not open up the other sinuses. We would see this double shadow representing that zone of apposition, which would be going all the way up to the sinotubular junction. And while that would give us a good minor axis, we can reliably understand where the nadir is for the right coronary leaflet, but we don't really know where to place this line where the virtual basal ring plane is below this commissure between the non and the left. We can do that on multiplane reformatting with both 3D echo and CT, but we can't reliably do that with two-dimensional imaging. So if we come back to this slide here, then, so if we get that same cut from the center of the right coronary sinus to the opposite commissures between the non and the left, we again will open up that right sinus by echo. We'll reliably identify that lowest attachment where the virtual basal ring plane is, and we'll see that leaflet. And then we'll get that double shadow representing the zone of apposition between the non and the left, going up to the sinotubular junction. And that plane would give us a minor axis of the virtual basal ring. However, if we do get to the center to center of both of the non and the right coronary leaflets, then we'll open up both of those sinuses. We will identify the virtual basal ring plane, but like I showed you in that other panel, we'll be measuring obliquely and under measuring a dimension that doesn't really represent in a good way this oval shaped structure, the dimensions of this oval shaped structure. So we've gone forward in adult patients, and we've now, since there's not understanding of normal data for all these aortic root metrics, we've gone forward and we've measured in a large population of adults these different metrics of the free margin length, the geometric height, the commissural height, the effective height, and the coaptation length. And we've related them to the measurements of the virtual basal ring, the sinotubular junction, and the sinuses. And this is soon going to be published in Circulation Journal. And I don't want to get lost in the weeds in this data here, but the important message I want to relay is that what we've discovered is when we relate these common measurements of the virtual basal ring, the sinus of Valsalva, the sinotubular junction, and we relate that to these different metrics like the geometric height, the free margin length, the effective height, the coaptation length, they have a predictable relationship where there's physiological compensation to maintain optimal coaptation. And we've even gone as far as to describe this in a mathematical way of how these different structures relate to themselves. And why this may be important is that this potentially could serve as a roadmap for the surgeon when he's trying to repair the congenitally malformed valve into a tri-leaflet valve, and he's trying to replicate that optimal coaptation found in the valve. He could relate how he may want to manipulate the size of the virtual basal ring or the sinus of Valsalva or sinotubular junction to some of these other important metrics. So the last thing I wanted to go over was just to give you a sense of this surgical planning. So I personally prefer CT imaging for this because of the high spatial resolution. The Hans Schaefer group also is doing this with three-dimensional echo, and that certainly can be done with the multiplanar formatting. But here you see a very nice four-dimensional image of a unicuspid aortic valve showing the raphe both between the right and the left coronary leaflets, as well as between the non and the right. So that orifice goes from the center of the valves, posterior and leftward, the typical unicuspid aortic valve. So with this three-dimensional CT data, we're able to make very detailed measurements of these different metrics, including the virtual basal ring and the sinotubular junction. So I just wanted to leave you with one case example. So this is a 16-year-old patient that had history of transposition of the great arteries and had an arterial switch operation, who then went on to develop severe neo-aortic insufficiency. And in this specific data set, I'm not able to bring out the bellies of the leaflets that well, but you can clearly see this central coaptation deficiency, which is nothing that you wouldn't be able to see by two-dimensional echo. But the importance of this data set is then we can make all these different detailed measurements and look at the three-dimensional structure, both this blood-filled endocast image and now this virtual dissection image. And what I want to highlight is this pink is the virtual basal ring plane. And from that, I'm able to measure this effective height from the virtual basal ring plane up to the central portion of the leaflet tips to understand this important metric, the effective height. And normal for an adult is about 8 millimeters. And you can see from these measurements that non-coronary leaflet only reaches 4 millimeters, while the right and the left coronary leaflets both reach more that normal height for an older adolescent or adult of 8 millimeters. And if we come back and we look at the free margin length, or actually we'll look at this blood-filled image of the neo-aortic root, and you can appreciate this is the level of the sinotubular junction. The surgeon has reimplanted the coronary arteries superior and distal to the level of the sinotubular junction, which has led to this dilation extending beyond the sinotubular junction up into the ascending aorta. And if we come over to this virtual dissection image where we're at the level of the aortic valve leaflets, so this is the non-coronary leaflet, we're looking at a surgeon's view. This is the right, this is the left. I want to draw your attention to these yellow lines, which are measuring the free margin of each of the leaflets. And this non-coronary leaflet measures about 43 millimeters compared to the other two, which are about 5 to 10 millimeters less. So this non-coronary leaflet is larger. We know from the effective height, it's sagging down. So that is the mechanism of that central coaptation deficiency, is that non-coronary leaflet sagging down. So this information would help the surgeon to understand that he may have to try to reduce the size above the sinotubular junction. He may have to do a commissuroplasty specifically of the commissures involving the non-coronary leaflet, since that is the leaflet sagging down. But the important information to understand related to the virtual basal ring and this concept of rotation is if we look at this atrial septum here, normally the midline of the non-coronary leaflet would line up with the non-adjacent sinus. But you can see in this view, this root has significant rotation where the midline of the non-coronary leaflet is here. So much more rotated on our screen here to the left compared to where it typically would be. And the important aspect when we look at the virtual basal ring, which I've superimposed here over the root, we can see that the minor axis of the virtual basal ring lines right up with the midline of the non-coronary leaflet. So if the surgeon did an annuloplasty, which would reduce the size of this annulus and it would make it a more circular shape throughout the cardiac cycle, both systole and diastole, if he did it less than the major axis, which is right here, 31 millimeters, but more than the minor axis, which is 24 millimeters. So let's say he did 26 millimeters, he actually would enlarge it in this dimension, which would pull this leaflet out, and that would be detrimental to that effective height. It would be counterproductive to his repair. So understanding some of this very important detail of the virtual basal ring, of this variability in the rotational position, in the different metrics of the aortic valve leaflets, can help us hopefully to optimize and improve surgical repair. So that is all. I do have another case if you needed more time, but that was all I was planning to share today. And I'm happy to discuss after Professor Anderson's presentation.
Thank you very much. Very nice.
Well, good afternoon to you all, ladies and gentlemen.
Images.
Those of you who were watching last week will recall that we discussed the development and the anatomy of the arterial roots. And I put that into the context of the overall outflow tracts. So today we're going to move on from that theme, and we're going to discuss normal and abnormal anatomy of the overall outflow tracts. So you will remember from last week that I argued that we could analyze the outflow tracts in tripartite fashion. And on that basis, we're able to recognize the intrapericardial arterial trunks, the arterial roots, and the ventricular outflow tracts. That is going to be the theme on which we're going to discuss the malformations. Because when we look at the way we can find problems in the outflow tracts, again, we can look at it in tripartite fashion. So we can consider subvalvar, valvar, and supravalvar obstruction. And here we are rotating around the arterial roots, which was our focus during last week's presentation. I'm also going to emphasize today the difference between the left and the right ventricles, because it is the difference in anatomy that underscores the different types of lesions we're going to be discussing, although the principles of analysis are the same for both the outflow tracts. So when we discussed development last week, I emphasized for you the importance of distinguishing between the extrapericardial and the intrapericardial arterial pathways. Next week, we're going to be considering the malformations in the extrapericardial pathways, in particular, coarctation and interruption. And I discussed with you how the extrapericardial pathways derived from what we call aortic sac and the pharyngeal arch arteries. And we'll come back again to that next week. But let's come back to the theme we established last week, the fact we could analyze the intrapericardial components in tripartite fashion. And I hope you will remember this picture. It's a long axis section through the developing outflow tract in a human embryo at Carnegie stage 16. Now at Carnegie stage 16, this is around 38 days of development subsequent to conception. So this is between the end of the fifth, the end of the fifth and midway through the 6th week of development. It's the equivalent in murine development to 12.5 days of development. And what you can see is the pinch in the outflow tract that is showing us the margins of the pericardial cavity. And what we discussed is how we can now recognize at this stage a distal part which has non-myocardial walls. And this separates into the intrapericardial aorta, the intrapericardial pulmonary trunk. we discussed at great length last week how the middle part of the outflow tract, which retains its myocardial walls at this stage, becomes transformed into the arterial roots. And then the proximal part of the outflow tract, again with myocardial walls, forms the ventricular outflow tracts. I also discussed with you last week what happens to those outflow tracts, because I showed you how it was myocardialization of the proximal cushions that produced the subpulmonary infundibulum. But I emphasized to you also that although at the start of development, as the aortic root is moved into the left ventricle, it still possesses a complete infundibulum. With the progression of time, that myocardium is taken away with the development of aortic to mitral fibrous continuity. We still are not sure how that process takes place, but as I'm going to show you, the difference in infundibular morphology is key to understanding the malformations, the outflow tracts. So let's emphasize for you again the anatomy of the normal outflow tracts. So here I'm showing you a cut that is replicating the oblique subcostal cut you make as echocardiographers. And what we see is the completely muscular sleeve of right ventricular myocardium that lifts the pulmonary valve, middle of the outflow tract, away from the base of the ventricular mass. And then at this dogleg in the right ventricular outflow tract, we find the pulmonary trunk, which is exclusively intrapericardial, and that extends to the margins of the pericardial cavity before it divides into the right and left pulmonary arteries. Now, the influence of the completely muscular infundibulum is that all of the leaflets of the pulmonary valve have myocardial support, and as we will see, that is important. We should also emphasize that there is an extracavitary area that separates the subpulmonary infundibulum from the aortic root. And that is why in the normal heart, we now know there is no muscular outlet septum. But we discussed last week how the outflow tract for the left ventricle in particular was ovoid rather than being totally circular. And over the course, since our discussions last week, I've consulted with Justin Tretter, my good friend and colleague who works in Cincinnati Children's Hospital. And Justin, like Shumpei Murray, has been doing some exquisite virtual dissections. And this is one of Justin's virtual dissections showing you the infundibulum of the right ventricle at the level of the virtual basal ring. So Justin has cut the infundibulum at the nadirs of attachment of the three pulmonary valvar leaflets. So there you see the left ventricle giving rise to the aortic root, but we're concentrating on the pulmonary root. And there is the subpulmonary infundibulum uniformly supporting the leaflets of the pulmonary valve. And in the right ventricular outflow tract, as we see here, just as in the left ventricular outflow tract, there is a difference between the dimensions of the subpulmonary infundibulum, but this is in ventricular diastole. When we look at right ventricular systole, we see that in fact the infundibulum of the right ventricle becomes much more circular. So now its dimensions are very nearly the same, although you will see that it's still a little bit ovoid. So we need to be precise as to how we take our dimensions so to establish the area of the pulmonary root. And I'm hoping that Justin might be able to come on and discuss this with us at the end of our presentation today. But here, now I've shifted the focus to the left ventricular outflow tract, but still we see the infundibulum. You can see that it's just supporting one of the leaflets of the pulmonary valve, lifting it away from the base of the ventricular mass. And again, we see that extracavitary area separating the infundibulum from the aortic root. So there is the aortic root. And now what I want to emphasize again is that it is only two of the leaflets of the aortic valve that have myocardial support. They are the leaflets supported by the sinuses adjacent to the infundibulum, the non-adjacent and the non-coronary sinus on almost all occasions. Its leaflet is in fibrous continuity with the leaflets of the mitral valve. And here again, we discuss the dimensions of this ovoid outflow tract. And Justin was able to confirm this with me. So here is a cut across the aortic root, again in diastole. You see there that we can see the mitral valve. And again, Justin has cut the virtual data set at the level of the nadirs of attachment of the valvar leaflets. So this is the virtual basal ring. And in diastole, as we discussed last week, there is a significant difference in the dimensions from front to back as opposed to side. But now again, when we look at the arrangement in ventricular systole, we can see that there have been dynamic changes during the cardiac cycle. And now that short axis dimension has itself expanded. The myocardial component of the septum has moved away from the area of fibrous continuity with the mitral valve, and now it is much more circular, but not quite a complete circle. So again, we need to be aware of these differences when we are making dimensions of the arterial roots in the clinical setting. But now let's move on and let's look at the malformations in the setting of what we now know about the anatomy. And here is where I'm going to come back to the tripartite approach, and now I'm going to discuss with you malformations in terms of subvalvar, valvar, supravalvar obstruction. And the key point here is the fact that, as we have seen, the leaflets of the pulmonary valve, the normal right ventricular outflow tract, have myocardial support for all three leaflets. And that influences both valvar and subvalvar obstruction. So when we see subvalvar obstruction in the right ventricle, when we see it with intact ventricular septum, it is concentric. And we see that as concentric infundibular obstruction. And you all know that when you are doing pulmonary valvotomy, oftentimes when you relieve the valvar obstruction for pulmonary stenosis, you still have that circular infundibular obstruction. But rarely we can find another form of malformation, and that is by the development of these so-called windsocks. This, in fact, is a windsock that developed from the eustachian valve, and it blew all the way through the tricuspid valve, through the right ventricle, and was obstructing the right ventricular outflow tract. I'm aware of similar windstocks having been developed from the membranous septum. They are rare, but you need to be aware of them. But much more usually, the obstruction subvalvar level in the right ventricle is infundibular obstruction. And we see that particularly well when there is a ventricular septal defect. And of course, this is the essence of what we see in the tetralogy of Fallow. So here very nicely we see that infundibular obstruction in the setting of tetralogy. And it is because now we can recognize a muscular outlet septum. It's deviated in anterocephalad fashion. And together with this hypertrophied septoparietal trabeculation, we have a squeeze, a circular squeeze at the mouth of the subpulmonary infundibulum. In this instance, we have a dysplastic pulmonary valve, and this shows you that obstruction at subvalvar level oftentimes, in fact, frequently goes along with concomitant obstruction at valvar level. But we also need to remember that on occasion, rarely, the outlet septum can be fibrous rather than muscular. And here we see a very nice example of where in tetralogy of Fallow, it is the fibrous outlet septum that is maligned in anterocephalad fashion, giving us a juxta-arterial ventricular septal defect, again with problems of the pulmonary valve. In this instance, the pulmonary valve is bifoliate. And indeed, in 2/3 of examples of tetralogy of Fallow, we can find pulmonary valves with only 2 leaflets, showing us that subvalvar obstruction can go along with problems at valvar level. So let's now focus on valvar obstruction, and let's think of the ways in which the arterial valves can become stenotic. And this is good not only for the pulmonary valve, but as we'll see, also for the aortic valve. And most typically, there is fusion along the zones of apposition, and that is what we call commissural fusion. But obstruction can be produced simply because of dysplasia of the leaflets. And in most instances, particularly in the pulmonary valve, when we have this so-called commissural fusion, that is accompanied by tethering at the sinutubular junction. And this emphasizes another of the features I'm going to point out to you, that the sinutubular junction is part and parcel of the mechanism of the normal valve. So if we draw a valve, you know that it is the attachment of the zones of apposition between the leaflets at the sinutubular junction that we call the commissures. And when the valves become stenotic, they do so in most instances by silting up these zones of apposition. So when we see minimal silting or fusion of the zones of apposition, the valvar stenosis is not great, but the more the fusion of the zones of apposition, the commissural fusion, progresses towards the center of the valve, the more severe is the valvar stenosis. And the end result is the pinhole arrangement that we see in so-called critical pulmonary stenosis. And here is a specimen that is well on the way to becoming critical pulmonary stenosis. And this is the essence of pulmonary valvar stenosis. There you see the fusion of the zones of apposition at so-called commissures, and you see that they have progressed in uniform fashion towards the centroid of the valvar orifice. But there is also what we call tethering at the sinutubular junction. The overall effect is to produce this volcano formation to the typical stenotic pulmonary valve. And this is the arrangement that nowadays most of you will deal with in the interventional laboratory, but the surgeons are also able to do a very nice job, and they can take care of this tethering at the sinutubular junction. But there is another consequence, and this I will emphasize in the setting of the aortic valve, because as those zones of apposition fuse together, increasing the valvar stenosis, so there is a reduction in the hinge points of the valves, leading to a much more annular arrangement. And this is what I'll emphasize in the aortic valve, what I call the annular paradox. The more severe the valvar obstruction, the more ring-like are the hinges of the abnormal valvar leaflets. But remember again, the sinutubular junction is an integral part of the valve. So when you see narrowing and tethering at the sinutubular junction, that is part and parcel of the valvar obstruction, and that can produce the waste, which we often consider to be supravalvar obstruction. But then, of course, you're well aware that we can also have narrowing in the pulmonary trunk, and this is intrapericardial. We see that typically in the setting of Williams syndrome, when it involves not only the pulmonary trunk, but also the intrapericardial aorta. And you see that much better than do I as an anatomist. So let's now move on and let's talk about left ventricle. And here the key to our approach is the fact that it is only those leaflets of the aortic valve supported by the sinuses giving rise to the coronary arteries that have myocardial support. And I can show you that by cutting away the valvar leaflets and emphasizing their crown-like configuration. So here I've taken away the valvar leaflets and I've opened up the left ventricular outflow tract. So there you see those two sinuses that give rise to the coronary arteries. You can see the opening of the right coronary artery. And there you see that the base of these leaflets is supported by myocardium. But then when you look at the non-coronary sinus and its leaflet, you see very beautifully the fibrous continuity with the aortic leaflet of the mitral valve. But what I also want to emphasize again is the presence of these fibrous interleaflet triangles. And they move all the way up to the sinutubular junction. They are part of the ventricle, even though they are fibrous, just as the myocardial support of the coronary leaflets is part of the valvar sinuses, even though it is myocardium. And we discussed these interesting points of anatomy of the arterial roots last week. So let's now see how they impose upon the malformations. But we're going to start by looking at subvalvar obstruction. And there are many more variants to consider here in the context of subvalvar obstruction when we look at the left ventricular outflow tract than there were when we were discussing the right ventricle. So here, a key part of subvalvar obstruction in the left ventricle is bulging of the ventricular septum. As we will see, that can narrow significantly the outflow tract. Oftentimes, it's made worse when there's a fibrous ridge or tunnel-like configuration on the septal surface. It doesn't always go with a septal bulge, but if there is a septal bulge, it can be made much worse by the fibrous ridge. Tissue tags become of importance here. They don't tend to blow out quite so much as we see in the right ventricle, but certainly, as I will show you, they can obstruct the subvalvar outflow tract. Also important, very rare, but on occasion, tension apparatus of the atrioventricular valve can be tethered along and across the outflow tract. But in the setting of a ventricular septal defect, what we're going to be concentrating upon is posterocaudal deviation of the outlet septum. Now here is the consequence of bulging of the ventricular septum. And this, of course, is hypertrophic cardiomyopathy. It's asymmetric septal hypertrophy. We also see the same situation in Pompey's disease, glycogen storage disease, but typically this is what you see in the setting of hypertrophic cardiomyopathy. And there is the asymmetric hypertrophy of the ventricular septum, and as you see, it is narrowing the subaortic outflow tract. But it can be made much worse if there is a fibrous shelf on the surface of the hypertrophied ventricular septum. And here's a very nice picture of that fibrous shelf. In this instance, we don't have septal bulging, but the fibrous shelf is significant. And there you see it is attached to the ventricular septum. It overlies the left bundle branch. And so that is a very significant relationship for the surgeon. But when it is severe, you see it extends all the way towards the mitral valve. And it also extends up towards the leaflets, the aortic valve. And it is a flow-related phenomenon. There have been 1 or 2 cases found during fetal life, but for the most part, this is an acquired disease of postnatal life, and there's a lot of evidence to show that it's related to abnormal flow up the outflow tract. It can be removed at surgery, and this is a very nice example of the shelf-like configuration that has become a diaphragm, a subvalvar diaphragm. This was removed by my late lamented friend and colleague, Benson Wilcox. The problem, of course, since it's flow-related, it can come back again. but with care, it can be safely removed and the outflow tract obstruction can be relieved. Many people still call this a subaortic membrane. To me, it's far from membrane-like. It is thick, it is fibrous tissue, and I would much rather call it a shelf or a diaphragm. The key point, it is flow-related, and significantly, it belongs to the left ventricle. So here's another nice example of such a fibrous tunnel in this instance, again extending onto the aortic leaflet of the mitral valve, but this time the left ventricle is supporting the pulmonary trunk because this is transposition. The key here, anything that produces subvalvar obstruction in the setting of concordant ventricular arterial connections will produce subaortic obstruction. When the ventricular arterial connections are discordant, exactly the same lesions will produce subpulmonary obstruction. And we're going to see that as we look at fibrous tissue tags. Here, in fact, you see the tissue tags in the setting of a common atrioventricular valve. So this is subvalvar obstruction produced by tissue tags in the setting of atrioventricular septal defect. But here again, we have very nice tissue tag that is obtruding into the left ventricular outflow tract. But this is the right-sided morphologically left ventricle. The right-sided morphologically left ventricle is supporting the pulmonary trunk. So this is subpulmonary obstruction in the setting of congenitally corrected transposition. And tissue tags are a quite frequent form of subpulmonary obstruction in this setting. But we can also see them here when the left-sided morphologically left ventricle is supporting the pulmonary trunk. So this is regular transposition. So here, because of the discordant ventricular arterial connections, the tissue tags are producing subpulmonary obstruction, but it is still subvalvar obstruction of the morphologically left ventricle. So let's move on and let's look what happens when we have a ventricular septal defect. So here I've opened the morphologically left ventricle in clam-like fashion, and I'm showing you a muscular outlet ventricular septal defect. But what you see here is that the muscular outlet septum has now been deviated in postero-caudal fashion. This is the opposite to what we saw in the setting of tetralogy of Fallot, and now it is obstructing the subaortic outlet. But here it is a muscular outlet septum. Remember, we can have exactly the same situation when we have a juxta-arterial ventricular septal defect if the outlet septum is fibrous. So here, with concordant ventricular arterial connections again, the postero-caudal deviation of the fibrous outlet septum is again producing subaortic obstruction. The message here, of course, is, as my good friend Richard Van Prague emphasized, and as we discussed last week, in the setting of left ventricular outflow tract obstruction, all the woe lies below. So all those lesions we've been looking at, they presage the possibility that there can also be problems in the aortic arches. So whenever we see the subvalvar obstruction, we should be anticipating either aortic coaptation or interruption. And remember also, when we have that subvalvar shelf, that can be part and parcel of Schoen's syndrome. But now, let's move on and let's look again at the arterial roots. And let's look at aortic valvar stenosis. Now, those of you who deal with neonates will know that when we have valvar stenosis in the neonatal period, it's what we call critical aortic stenosis. And almost always, in my experience, when I see the hearts that used to be found in this combination, because it was a very difficult situation to treat 10 or 20 or 30 years ago, almost always those valves when we looked at them carefully, had the so-called unicuspid and unicommissural arrangement. It is this arrangement that shows us the loss of the semilunar hinges. And we see that the leaflets are attached in annular fashion, oftentimes associated with severe hypoplasia of the left ventricle. And when that is combined with endocardial fibroelastosis, in essence, we're looking at part of the hypoplastic left heart syndrome. But this is what the valve typically looks like in that setting. Here we're looking down on it from above, and we've opened out the aortic, the intrapericardial aorta, and you see that the essence of the valve is that there is only one zone of apposition between the sleeve, the skirt of leaflet tissue that reaches up to the sinutubular junction. But when we look carefully, we can see that there are two raphes. And this tells us that this valve initially started with 3 sinuses, but 2 of the zones of apposition of the leaflets supported by those sinuses have silted up, this time leaving us a solitary zone of apposition. So this is what it looks like when we look at it from the inside. And now, because those zones of apposition have silted up, it's commissural fusion, we have vestigial interleaflet triangles with but a solitary zone of apposition leading up to the sinutubular junction. And in my experience, this zone of apposition is always pointing back towards the mitral valve. And I believe this reflects the fact that it is those 2 leaflets supported by myocardium, it is their zones of apposition that silt up, leaving the zone of apposition between the non-coronary leaflet and the left coronary leaflet pointing back towards the inlet of the left ventricle. So if I draw you a picture to show you what's going on, there you see the solitary zone of apposition, and as you see, I've drawn that back into fibrous continuity between the non-coronary, left coronary leaflets of the aortic root and the aortic leaflet of the mitral valve. And I'm showing you that fused zone of apposition, commissural fusion, associated with a vestigial interleaflet triangle. And in the unicuspid unicommissural valve, there will be 2 of these zones of apposition that have silted up. Again, I'm going to emphasize for you this annular paradox, because what we know is that normal leaflets are attached in crown-like fashion. They lack an annular attachment. Paradoxically, the worse the degree of valvar stenosis, the more obvious is there an annulus. So now let's move on and let's look at the valve with 2 leaflets. In fact, the bicuspid aortic valve is the commonest congenital lesion. If we are to describe it properly, we need to distinguish between leaflets and sinuses. So I'm not going to talk about cusps at all. In fact, as you see here, I've put it in inverted commas because I've already shown you that in the so-called unicuspid and unicommissural arrangement, we find 2 raphes. In the so-called bicuspid valve, there is typically formation of 3 sinuses, but there is only 1 raphe formed because 2 of the sinuses unite to form the so-called conjoined sinus. But if we look very carefully at these individuals with so-called bicuspid valves, on occasion, we can find them not only with 2 leaflets, but also with 2 sinuses. So for me, if I'm going to categorize the aortic valve with 2 leaflets, I'm going to concentrate not only on the sinuses, but also the leaflets. So we can have the so-called bicuspid valve, which is trisinuate. And then in about half the cases, we find that it is the right and left sinuses supporting the coronary arteries that are conjoined. In the other half, it is the right coronary sinus and the non-coronary sinus that are conjoined. It is exceedingly rare to find conjunction between the left coronary sinus and the non-coronary sinus. And as yet, we're not sure why that should be. We do know, however, that there are differences in the clinical behavior of individuals having these other types of conjunction, and that is why it is so important to establish the precise phenotype. And that is why we also need to recognize that on occasion we can find heart valves that are not only bicuspid, but also bisinuate. We've already discussed how in the unicuspid and unicommissural valve, the root is trisinuate, but two of the zones of apposition have silted up. So I've shown you that in that unicuspid and unicommissural arrangement, two of the interleaflet triangles are vestigial. You will immediately appreciate, I hope, that in the so-called bifoliate, bicuspid arrangement, if we have three sinuses, only one of the triangles will be vestigial. Whereas, if we have that rarer form, where there are not only two leaflets, but also two sinuses, there will only be two triangles because there will be no conjoined leaflet. And here is where we come back to virtual dissection. And so this time I'm showing you again the exquisite images produced by my friend and colleague Shumpei Mori. You'll remember I told you last week that Shumpei was originally from Kobe. He's now moved from Japan. He's working at the University of California in Los Angeles, and he's working with Kalyanam Shiv Kumar. And these are the exquisite pictures he made whilst he was still in Japan, showing you the phenotypes of the aortic valve with two leaflets. And so there you see the fused zone of apposition between the two sinuses supporting the coronary arteries. So this is the phenotype with conjoined aortic sinuses. Remember that the virtual plane in the setting of the aortic root is ovoid rather than circular. And in this arrangement, the zone of apposition is in the long axis of the ovoid virtual plane. Now here, Shumpei has taken that data set and has shown you what has happened to the crown-like configuration of the hinges of the bicuspid valve. So there you see the conjoined aortic sinuses, and you see that the interleaflet triangle is now vestigial. The part of the crown on that side has lost its crown-like configuration and is much more circular, but still we have the two interleaflet triangles between the conjoined leaflet and the non-coronary leaflet. So here is the other variant, again shown beautifully by Shumpei's virtual data set. This time, the zone of apposition is between the left coronary sinus and the conjoined right and non-coronary sinuses. And there, when you look down into the base of the conjoined sinus, you see the fused zone of apposition between those leaflets, the so-called raphe. And now, when we look at the ovoid virtual plane, we see that the zone of apposition between the conjoined leaflet, the left coronary leaflet, is now in the short axis of the ovoid plane. This is what it looks like when I show you an anatomic example. There beautifully you see the raphe. There is the vestigial interleaflet triangle, and there is the zone of apposition and the other zone of apposition. Shumpei can now show you what it looks like from beneath. So this is another instance. It is that individual has the conjoined leaflet between the non-coronary sinus and the right coronary sinus, and there you see the virtual interleaflet triangle and the site of the raphe with the lack of hinge-like semilunar attachments of the conjoined leaflet, producing a much more obvious annular effect. We can also now explain why we have this, because I showed you last week during development how the major cushions fuse to divide the aortic from the pulmonary root during development. It's now easy to see that if that fusion is excessive, we can have conjunction of what would be the developing coronary arterial leaflets, whereas if you have conjunction with the intercalated swelling, that would give right non-coronary sinus fusion. If, however, the intercalated swelling does not form at all, then that would give us the bisinuate and bifoliate arrangement. So let me finish by discussing with you supravalvar obstruction rather. And I want to emphasize again is that this obstruction typically involves the sinutubular junction, and that is part and parcel of the valvar mechanism. And it is obstruction of the sinutubular junction that gives us the so-called hourglass variant. And that is the commonest type of so-called supravalvar obstruction. On occasion, rarely, it can be produced by a diaphragm. When there is involvement of the intrapericardial aorta, as in Williams syndrome, then we have the tubular variant. But let me show you this very nice example of the hourglass variant. Because there you see that the hourglass is produced by a waist-like pinching in at the level of the sinutubular junction. And this tells you that this is part and parcel of a valvar problem. And now, because there is constriction at the level of the sinutubular junction, the leaflets are longer than the sinuses. And that is why the surgeon, when replacing the so-called supravalvar obstruction, has to widen out the sinutubular junction so as to let, once more, those leaflets open out properly and relieve the stenosis, not only at the level of the sinutubular junction, but also within the overall arterial root. So what I've tried to show you is that with our knowledge of normal anatomy, combined with what we know now about development, we can provide a rational basis on which to understand obstruction of the ventricular outflow tracts. I hope you've appreciated now that it is the difference in anatomy between the right ventricular, the left ventricular outflow tract that underscores the various lesions that I've been demonstrating for you. And again, we've been approaching it in tripartite fashion. We can look at development in tripartite way. We can look at the overall anatomy in tripartite fashion. And now we can analyze malformations on the basis of subvalvar, valvar, supravalvar lesions. But do remember, these lesions, although I've discussed them with you on an individual basis, they can all combine together. And again, I would emphasize that they can be found along with problems of the atrioventricular valves and the extra pericardial pathways, as we find in the setting of Schoen's syndrome. But next week, we'll be concentrating on those extra pericardial pathways. As I say, then I'll be discussing with you coaptation and interruption.
Thanks, Bob. Perfect.
Very good, amazing session. And Justin as well, very beautiful images and a very nice new way of seeing these things of non-invasive imaging. Congratulations, very, very nice.
Thank you.
So we have a couple of questions on the Q&A chat box. Guys, please type your questions and your comments, and this is going to be useful for our discussion. So I think to start, I want to know if Dr. Silverman has an initial comment about the two talks.
Well, yes, thank you very much for allowing me to participate and comment by this. So firstly, I'd like to welcome Justin and congratulate him on his very interesting work. Last week, I asked Bob the question that is a day-to-day problem in the echocardiographic laboratory, and that is, how do you measure a aortic or pulmonary flow with all of these variations? It's easy to get a Doppler signal, but where do you measure the dimension? Because that is fundamental to accuracy. I've been thinking about this since I asked Bob this question last week. And of course, once again, another three-dimensional technique seems to be valuable, and that's with MRI, because MRI can measure the flow over the whole valve area and also summate all of the different voxels that occur to get an accurate measurement. But from fetal measurements onwards, we are measuring cardiac output and combined ventricular output by summating the aortic and pulmonary flow in conditions where the valve is reputedly normal, because you won't be able to do it with the velocity as abnormal. So Justin, I know this is a curveball for you, but as an echocardiographer, can you tell me how I must measure the annulus with so-called annulus, intrapericardial sinuses, supravalvular area? Where do I make my measurement?
I think my presentation creates more questions than answers. And I'm an imager, but I also run our cardiovascular genetics clinic with a large cohort of aortopathy patients. So I see not only my own measurements, but my colleagues' measurements of aortic annuluses as we follow these patients serially. And that is one of the measurements that just does not seem accurate. I see it jump around bigger, smaller from every 6 months to a year that we follow these patients. And now you know why, looking at these three-dimensional data sets, where some of the inaccuracies come from. So I don't have a great answer. I think that we have to be skeptical of the two-dimensional echo annulus measurements, and especially when we then try to put it into the continuity equation, where there's going to be, you obviously know, and I'm sure those listening know, not only the annular measurement, but also when you're taking that pulse wave and where some of the errors can be amplified in that equation. So I think that there are huge limitations to the echocardiographic assessment of the continuity equation. And like you mentioned, MRI is definitely the gold standard for flow. MRI's limitation is going to be the spatial and temporal resolution when you're trying to understand the details of the aortic valve anatomy and the surrounding structures.
I ask a question here, because this was what we discussed last week. And last week, Norman and I, you weren't there last week, Justin, but Norman and I had the discussion about the different levels of the outflow tract. And one of the things we were discussing is that the sinutubular junction is, in fact, circular. Is there any reason we shouldn't use the sinutubular junction as a measurement area for use in the continuity equation?
I'm involved, as you know, some of the work that we're looking at with this is computational fluid dynamics and trying to understand how some of these variabilities in the interleaflet triangle heights and how that changes the angle of the aortic valve opening orifice and how that changes the resulting tissue biomechanics. And we're also looking at how this root rotation impacts the hemodynamics and tissue biomechanics. And one of the limitations in simulation studies where they've used MRI phase contrast data at the sinutubular junction, there's an adult paper that looked at phase contrast at the sinutubular junction and at the aortic valvar plane. And there's significant difference, not only accounting for the coronary artery blood flow that you're losing, but even beyond that, there's differences in that flow. So no, that would not be a great representation.
Okay, the best laid schemes of mice and men. Norman, how do you come back to Justin's comment? You've thought about this throughout.
Well, I think one has to be skeptical about this. Of course, errors get small in the fetus, of course. I mean, just ability to make an accurate measurement when you have a half a pixel or a half a millimeter can make tremendous differences to the cardiac output. So, I mean, I've always been skeptical about the Doppler measurements for doing this, but that's what we've got. And I think that from this conversation until, I mean, we have to, there are at the moment 166 people listening to what we're saying, and there are going to be many more that are going to revert to the web broadcast of this on YouTube. And we are going to need to have a recommendation. And Justin, I would say that the virtual ring at the base of the sinuses of Valsalva is probably the best place to make this measurement. I think a lot of people are actually using this particular measurement of the so-called annulus for Doppler calculations.
And you're referring to two-dimensional echo?
Yes, I'm referring to, yeah, to what what do they call it? Bread and butter echocardiographers.
Yes.
Like myself. Norman, is whether you're going to do nadir to nadir or nadir to connoisseur, because that Justin showed you can get a what? Up to 20% difference between those measurements. Absolutely,
I understand.
Right, and I think the big takeaway message with 2D echo imaging, when I showed those images, that panel of the aortic root short axis, the virtual basal ring short axis, and the long axis of the LVOT and aortic root, was when you're hovering in the sinuses, you, as an echocardiographer, you need to find the widest measurement there, right. And that opens up the valve annulus, and it may be cutting obliquely across that oval structure, but it's probably going to be the closest that you can get to some representative dimension of that oval structure.
Yeah, I think that the point that this week and last week highlight, I don't want to spend too much time on it, is how important it is to make as accurate a dimension as you possibly can. And I think that this is sort of very glib in terms of measurement in the works that we read on this particular topic. But there's one other issue, if I may, Justin, of course, is that we talk about systole. And systole, as I mentioned last week, the aortic root has a dynamic change in systole as well. Mm-hmm. So where do you make the measurement? Do you make it in mid-systole? Do you make it in early systole? Do you make it at end systole? And I think that's nothing that is clearly articulated in our measurement.
That was the comment I was going to make, because I thought that the dynamic pictures that Justin showed, I mean, I've not been bold enough yet to try to show moving pictures in any of my presentations, but I thought that Justin's dynamic pictures, both with his echo and then also with his dynamic CT, I think it was CT, wasn't it, Justin?
Correct, yeah.
I think those pictures were quite spectacular. And the point you make, Norman, when you see things like that, you are aware of the dynamic changes you see during the cardiac cycle. And that must also be highly significant.
Yeah, well, we know that with exercise, Justin, I don't know whether you've done any exercise dynamic changes, but the whole zone of apposition of the leaflets may change because the aortic root can increase its size by a fifth during exercise. So, I mean, it becomes really difficult to understand even the metabolic status of the patient when you're making these measurements.
Right, that's an important concept. And I think the difference between systole and diastole, most pediatric programs measure in systole, most adult programs in diastole. Systolic annular measurements may be more reproducible, even if you're cutting across an almost circular structure. In systole, that's going to be more representative of the dimensions than if you're getting an oblique cut across the more ovoid structure in diastole. So that's where the benefit of systolic measurement of the annulus may be for the pediatrician.
Just as an aside, before we move on, Grace, do we record the discussions when they go on to the, when we host it on the Congenital Heart Academy?
Yes, it's going to be available. It's going to be available, the discussion as well.
Because last week and this week, I think the discussion is almost better than the presentations themselves.
Well, Bob, I think, again, the problem with today's session is I would, as a participant, that I would say is that many of the questions that have been posed today in my own mind will only be answered when I review the YouTube signals again and again, because there is a huge amount of information that you have put to us about the interleaflet triangles and their significance, and the dynamic nature of subvalvar obstruction in the left ventricular outflow tract. And that itself is a dynamic lesion, which not so much in terms of where it is, but the important issue about subvalvar obstruction from my point of view is how much it damages the aortic valve. And I think that's a critical area for the leaflets of the aortic valve, because it depends where this membrane forms.
It's not a membrane, it's a shelf.
So it is.
Habits,
so it is.
Oh.
I acknowledge, Dr. Your colleague in London, Jane Somerville, in terms of that this is not a membrane. But the point at issue that's important is that this again is a dynamic lesion. And you and I wrote a paper in, I think it was in the 1980s, about subvalvar obstruction, and with the late Leon Gerlis, the late lamented Leon Gerlis, our good friend, who did histology on 17 of these membranes in your collection. And we noticed that in the early stage that this was a sort of single sheet-like structure, but that during the course of evolution after birth and to the stage of adulthood, that there appeared to be apparent huge fibrous ingrowths into this membrane, and eventually fusion can occur with the aortic valvar leaflets.
Absolutely.
So it becomes a very, very nasty lesion. And I think it's just an important point to emphasize about this very dense collection of information you've provided us. I should let somebody else talk now.
Grace, you have some questions to pose.
Yes, we have a lot of questions from the audience. We already have 1 hour and a half, so I don't think we're going to be able to do all of them, but for sure we are going to try to cover as much as we can. We have one first question that we were already discussing about the shelf, not the membrane, but Usha MK is asking, why does it recur after surgery?
I mean, there's no question that that is because it's flow related. And as Norman said, I mean, I'd forgotten the study we did with Leon Gerlis. And I mean, one of the points that comes out of that and that comes out of Norman's comments is that when it is a membrane, we probably don't recognize it. You will recall, Norman, that when we looked at all those hearts, we found many of these so-called shelves that were in membrane form, and they were barely evident. Leon had to look very hard to find them, and we wouldn't have picked those up in the clinical setting, would we? So we only see it, as you say, as the abnormal flow interacts with what is there and produces the shelf. I mean, would you not think that that's the evolution of these entities? We know they come back if you take them away.
Well, I think, yes, and you made an excellent point, Bob, about the fact that the left bundle is lying immediately underneath the shelf, as it were. And one of my colleagues had always insisted on seeing the histology that there was always muscle underneath the shelf, because if you leave some of the shelf, it can recur. And I think that the dynamic nature of the shelf with fibrous tissue, it's not just hemodynamics that is important, because there's a change that occurs histologically with these subaortic shelves with time. And in this group also, we were able, of those specimens that we looked at, to see this and when I looked at the entire collection, as early as 2 weeks after birth. And then it was fine and delicate. And as the patients grew, the membrane or the fibrous shelves became more and more fibrous and became almost candle waxing in older patients. So I think it's a dynamic lesion. It may not just be flow related, because if the dissection is not complete, there's membranous structures left on the anterior leaflet of the mitral valve. I think that this is one of the beautiful things that you showed in the specimen, that it really is a diaphragm and extends onto the mitral leaflet. So the dissection has to be really quite extensive in order to remove these things.
I mean, the relationship to flow, in fact, your good friend Terry Tacey, when she was in Pittsburgh, did some very elegant work with an engineer who was working in Pittsburgh at the time, called Ted Cope. Cape, was it Cape?
Ed Cape.
And I mean, I think they showed quite convincingly that this was flow related, did they not? Mark Gewillig from Leuven has also made the point of the rheology related to it all.
Yeah, I think that that's certainly an important issue. The question is, why does it occur in some and not in others? That's the $64,000 question.
Indeed.
Well, before we get into more questions, I just wanted to ask you one other thing, is that in talking about right ventricular outflow tract obstructions, you didn't consider the divided right ventricle. And I wonder whether this is just a time omission or deliberate on your point.
Well, I did discuss, in fact, the obstruction at the mouth of the subpulmonary infundibulum, which is, in a way, dividing the right ventricle into the infundibular component and the rest. But we were talking about outflow tract obstruction. And most of the time, what we call divided right ventricle is division of the apical component, is it not? So
correct.
That's not strictly an outflow tract obstruction, but I take your point that if you do get obstruction there, you can have obstruction between the inlet and the outlet. So I just didn't happen to think about that.
Okay, well, good. I just wanted to know whether that was an omission. Thank you. Thank you very much.
We are going to finalize with one question to Justin, and quite a few people asked about how to measure the annulus, in the sense to use this measurement for TAVI or percutaneous pulmonary valve implantation.
Yeah, that's a great question. And I also see the comment from our good friend surgeon, Dr. Adrian Crucian, who's saying that he just uses the Hagar dilator in the OR.
Yes.
And I think that that's a good point, because we get feedback from the surgeons and the interventionalists about our inaccuracies with MRI and echo assessment of the annular dimension. And again, I don't have a great answer. I can tell you the TAVR literature, there's a lot that the adults have looked at in terms of different valve types and what is the best way to size it. And we had done a TAVR study where we looked at how this rotational position potentially changes the relationship of the aortic root to the atrioventricular conduction axis, and could it potentially be a risk factor for increased incidence of conduction damage following TAVR. And I spoke with the chief medical officer of Boston Scientific to try to understand better what are they using to size these different valves. And there's really no great consensus, but the conclusion that we got from him was to take the minor axis, take the area of the virtual basal ring and to back calculate a area derived diameter as if it was a circle, because that's what's going to happen when you place in any pulmonary or aortic valve, is now you're going to change it to become more circular in structure. And so that's what we use. We took the area and we back calculated it to get an area derived diameter as if it was a circle. Whether or not that's the best way, I think that even the adult world who has more experience in this doesn't really know yet which is best for across the board for all the different valves.
Thank you very much, guys. This was an amazing session and it's getting better and better. So I hope everybody can join us on the next activities for the next few weeks. It's going to be very nice. And thanks again for joining us, guys. Thank you. Bye-bye.
Thank you, Grace. Goodbye, everybody.